Hello everyone, how are you all? Sorry for the late today. We just had some technical difficulty to do the live streaming in our Facebook group. So now it's fine. That's why actually we have been a little late today. But so thank you so much for joining in time. As you know that today is our the first session of our first aid AMC MCQ free 2 week session. We will start with the cardiology session tonight. And I hope the cardiology session will be a really important for all of you guys. And remember one thing for your MCQ, some of the important topics are always there. One of them is the cardiology. There will be always questions coming from cardiac. There are so many cardiac questions. So we'll go through most of those. And first, tonight, we are going to do the theory session. Probably we will need more than one class, obviously, for finishing the cardiology because there is a vast things to discuss. Tonight, we'll discuss the chest pain mainly, and after that, in our next sessions, we will go to the palpitations, heart failure, those topics. Okay, let's see that how many people have been joined so far. We will just start in 2 minutes time. Now, before we start the cardiology, let's just see that how our heart works. Normally, before starting a theory session, it's important to know the functions or the physiology of that particular system. I know that most of you know that how the heart works, but still for the purpose of the session, we'll just show you a video that's just a normal physiology of how heart works and how heart pumps and how all the circulatory system in our body works. Okay, so let's start.
The normal heart has two sides, a right side and a left side, and four chambers, the top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. Pulmonary artery splits into two vessels, each going to the lungs. As that red blood cell makes its way through the lung, it returns through the pulmonary veins to the left atrium. That blood is now oxygenated. It's picked up oxygen, then goes across the mitral valve into the left ventricle, which does most of the work in terms of delivery of blood flow to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
Right? So this is how our heart works. So normally what happens? You just give me a second. I think someone is sending messages in the Facebook. So this is how our heart works. We'll go through all this physiology, like how heart pumps and from where the blood comes and then from where to where blood goes. Just give you an idea. Let me draw a picture first. Before we start the cardiology, it's the vital things to know first, that how heart works and how everything works. Otherwise, it's nothing important than to know the physiology of cardiology first. So what happens, let's just assume that this is your heart. Okay. Now your heart has four chambers. You have right atrium, you have right ventricle, you have left atrium, you have left ventricle. Now from your superior vena cava and also from inferior vena cava, blood comes from the extremities into your right heart. And those bloods are deoxygenated blood or carbon dioxide blood. Now, that deoxygenated blood goes to your right atrium, and through the tricuspid valve, it enters into your right ventricle. And then from the right ventricle, there is a pulmonary artery here. So from the right ventricle, deoxygenated blood will go through the pulmonary artery into your lungs. So you have two lungs in your chest, and those deoxygenated blood will go from your right ventricle through the pulmonary artery into your lungs. Now, you know that all the arteries in your body carries oxygenated blood. Only one artery which carries deoxygenated blood, that's your pulmonary artery, right? So this pulmonary artery will carry the deoxygenated blood from your heart to the lungs. In the lungs, the blood will get oxygenated, and through the pulmonary vein, it will come to the left atrium. Now, from the left atrium, through the mitral valve, blood which is oxygenated will go to your left ventricle. And then from the left ventricle, here is your aorta, and this is the aortic valve. So oxygenated blood from the left ventricle will enter into the aorta and then goes to the whole body and supplies the oxygenated blood in our whole body system. So this is how the heart works. Now, why I discuss this one is important. You will know throughout the class that how these things will help you to understand everything that we are going to discuss now. Okay, so let's move on. Now, when we discuss anything like cardiology today, we need to have some resources to follow. Always keep these things in your laptop or from wherever you are reading. You should have these things in one place so that you can read it anytime you want. Obviously, you should follow the JM 7th edition, and this is our first thing to follow. So these are the chapters from the JM that we need to follow for cardiology. We will go through each of these chapters and we'll show you what are the important things you need to read from JM. Remember, from JM, you don't need to read everything, just the important thing we will go through. Then obviously you should give a reading from the Kaplan Step 2 CK Cardiology. That's your additional help you need, and it's very important to understand the basics. With this one, also keep another one which we call Muster the Board, MTB. Usually it's a fourth or fifth edition, so you can go with any of those editions. So Muster the Board is very good for medicine, so we will also take help from those Muster the Board book as well. Now, these are the main books that you need to go through and or take some help if you guys having any difficulty with understanding. After that, some of the websites are very good to give you like a precise idea about anything you want to know. Those are your e-medicine. E-medicine is very good. It gives you total free resources for anything you want to know for any particular disease. Just write, like you want to know about atrial septal defect, write atrial septal defect and add e-medicine with that, and then search it in your Google. You will find it out, and it's really good. After that, RACGP is also important because it's an Australian guideline. So you can search it by writing anything, like you want to know about myocardial infarction. So write myocardial infarction RACGP guideline, and Google will show you the RACGP guideline for myocardial infarction. This is Australian guideline, so it's a very important website to follow. There is one USA guideline, which is your med bullets. It's not very detailed, but it shows you the just the important thing that you need to know. And it's very, very good. I would say it's precisely it's written, and you can, and also there is a scenario is written before they start discussing any topic. So it helps you to understand the particular topic, and also shows you that what are the important things you need to know for this particular condition. So you can also take help from mid bullets. Then we have our own Q bank. So once you join our course, you will get the Q bank access. So after finishing the theory from the book, then go to the Q bank and read the Q bank questions. That will give you more idea. And also obviously follow our lecture note, which is very good for your cardiology. We usually gives you everything from all this book. We take the important topics and we keep it in our lecture note so that you can go through our lecture note without going through all this book. But still, I would obviously advise you at least go through this book once, because that gives you the confidence. And sometimes we may miss some of the topics, so that it's important to go through these books at least once. So these are the resources we will follow for the cardiology. Clear? And after you have done everything, then you will go into our software and you will appear our mock test for cardiology. And then you will assess yourself that how you know about cardiology and how much deficit you are still having. Good. So let's start. We'll start with the chest pain. So anytime if there is a patient in the question who is coming to you with a chest pain, you should always think about it could be cardiac causes, it could be respiratory causes, it could be gastrointestinal causes, okay? And sometimes more commonly it could be a musculoskeletal chest pain, or it could be neurological as well. What are the cardiac causes which can cause you chest pain? Very important to consider is myocardial infarction, or sometimes it could be just a stable angina or unstable angina. Another thing is pericarditis, which is inflammation of your outer covering of your heart, which we call pericardium. And in a 40-year-old woman coming to you with a occasional chest pain, and you get a murmur with a systolic click, that's your prolapse of the mitral valve. We'll go through this, just giving you some basic idea. Then you should think about prolapse of the mitral valve. Only one valvular condition, so not one, only two valvular condition usually gives you chest pain or chest tightness. One is this one, mitral valve prolapse, which usually common in female, and obviously there will be a systolic click. That's the clue for prolapse of the mitral valve. Another valvular condition which causes cardiac chest pain is your aortic stenosis. Also, it will give you a murmur, which is an ejection systolic murmur. The murmur radiates to the neck. So AS also give you the chest pain, but it's more common in elderly and also is more common in male people, but it can happen to the female as well. So these are the cardiac causes. Vascular aortic dissection is a very, very important cause of chest pain, especially elderly patient coming to you with a central chest pain, which is radiating to the back or in between the shoulder blade, and it feels like something tearing or shearing the heart. That's your aortic dissection. Then comes to the respiratory system. You have pulmonary embolism, you have pneumonia, pneumothorax. These are the main causes of chest pain. Pneumothorax, obviously, it's usually young patient comes to you with a sudden onset of shortness of breath with chest pain. That's most of the time pneumothorax, and they will give you an X-ray to find that out. Pneumonia, obviously there should be fever, cough, shortness of breath, and a kind of pleuritic chest pain. That's your pneumonia. What is pleuritic chest pain? If any chest pain gets aggravated with taking deep breathing or inspiration, that's your pleuritic chest pain. So pleuritic chest pain is most of the time pneumonia, pneumothorax. These two are very important and they give you pleuritic chest pain. Okay, and also sometimes pericarditis can give you pleuritic chest pain, although it's a little different because it's pericardium, not the pleura which is inflamed. Gastrointestinal causes very commonly comes with chest pain, so you should also consider peptic ulcer, esophageal tear or esophagitis, or gastroesophageal reflux disease. Musculoskeletal, like any patient, like a young patient coming to you with generalized chest pain. And when you ask a lot more history, they give you that patient is an athlete or patient goes to the gym. So after doing the lot of exercise and going to the gym, patient having a lot of muscle aches and generalized chest pain. You did ECG, nothing came up. You did the blood test, everything normal. So what is it? It's most likely musculoskeletal chest pain. Also, apart from that, there could be sometimes a condition called costochondritis or Tietze syndrome. Costochondritis is mainly you have the uh, the 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 cartilage between your like the between the ribs, okay, that costochondrium can get inflamed sometimes, and that is called costochondritis. We'll show you how this costochondritis pain comes up, but the very important clue for costochondritis is that they usually comes to you with a palpable swelling in the costocardiac joint. So that if you find out that in the costocardiac region, there is a palpable swelling which is tender to touch, that's most of the time costochondritis. Also, sometimes fractured rib can give you the chest pain. The last thing you should consider is a neurological, which is herpes zoster. Herpes zoster is a skin condition which comes to you starting with a pain in anywhere. Mainly they follow a particular dermatome, and after few days of pain, the patient usually starts to develop a vesicular kind of rash. And the rash is very painful and it's vesicular, and usually it's only follows one or two particular dermatome, and the rash doesn't cross the midline. That's your herpes zoster. So obviously these are the important things you should always consider when there is a patient coming to you with a chest pain. Clear? So we'll go through all these things. Now, starting with the angina or cardiac chest pain. So if any patient coming to you with a chest pain, which mainly gets worse with exertion or doing exercise, and it's an elderly patient, you should think about acute coronary syndrome, which contains stable angina, unstable angina, and later on myocardial infarction. That particular angina pain usually feels like a kind of chest tightness or heaviness or kind of pressure feeling in the left side of the chest. Never ever cardiac chest pain starts in the right side. It's always at the left side at chest pain. Another important thing, any patient can come to you with a epigastric pain. Any elderly or middle-aged patient coming to you with a epigastric pain, the first thing you need to rule out is myocardial infarction. So you should do an ECG to that patient, because sometimes the myocardial infarction pain can radiate to the epigastric region, and patient can present to you with a epigastric pain. And you might not even think that it's a MI patient. So any epigastric chest pain, any epigastric pain in a middle-aged or elderly patient, ECG is must. And for this angina or AMI patient, usually there will be associated nausea, vomiting, and sometimes they can feel very sweaty or diaphoretic as well. Some of the patient who has inferior MI, which means that this is your heart, if the myocardial infarction is in the base of the heart, which is the inferior MI, and usually you know that your heart is supplied by the right and left coronary arteries. Usually inferior MI happens when the right coronary artery is blocked. In case of inferior MI, then usually vagal reflexes or vagus nerve get stimulated, and those patients can have bradycardia, hypotension, and even sometimes they can present to you with a fainting or syncopal attack. So patients with syncope or faint or feeling dizziness, that patient also need to have a ECG if they are elderly patient, because that could be the only presentation for that particular patient. So what I have said, any patient coming to you, mainly middle-aged or elderly with epigastric pain, ECG must. Any elderly patient or middle-aged patient coming to you with a syncope or feeling dizzy or had a fainting attack or having bradycardia, hypotension, you should do a ECG for those patients. These are the questions comes in the exam to see that you know these important things or not. Next one, remember we said there is a condition called pericarditis. That pericarditis pain usually comes with a sharp knife-like chest pain. And patient can pinpoint the exact area where the pain it is. But myocardial infarction pain, patient usually cannot show you where exactly is the pain. But pinpoint, if a patient can say that I'm exactly having pain in this area, it's a kind of sharp stabbing or knife-like pain, you should think about pericarditis. And pericarditis pain, the special characteristic is that it gets worse when the patient lie down and it gets better when the patient lean forward. Also, if the patient takes a deep breath or inspiration, patient's pain gets worse. Clear? And pericarditis, those patients usually they give you a most of the time it's a reaction of the viral upper respiratory tract infection. So in the question they can give you a clue that patient had a viral flu-like illness about a week ago and now comes to you with a sudden onset of severe left-sided chest pain which feels like knife-like stabbing pain and get worse with deep inspiration or lying down and gets better with sitting forward. What is this condition called? Pericarditis. Now remember I told about stable angina, unstable angina and myocardial infarction. The timing is also important. Most of the time unstable or stable angina gets better within 10 minutes. But myocardial infarction, the pain usually lasts more than 20 to 30 minutes. That's one of the clue you should remember. If the chest pain is responsive to GTN or nitroglycerin, that's most of the time it's a stable angina or unstable angina, or it could be esophageal spasm. Remember, esophageal spasm is another condition which comes to you with dysphagia or swallowing difficulty with intermittent chest pain. So any patient having an intermittent chest pain with dysphagia, mainly to the solid, that patient is having esophageal spasm. And esophageal spasm also responds to the nitroglycerin. So any chest pain responsive to nitroglycerin it's either angina or esophageal spasm. But if you give nitroglycerin and chest pain get worse, that's most likely gastroesophageal reflux disease. And also myocardial infarction is not responsive to nitroglycerin. So sometimes it can happen like that. A patient had angina for a couple of years, and usually it gets to be responsive to nitroglycerin. But today, the pain is more than 20 minutes, and even with multiple time of nitroglycerin, the pain is not getting better. So that's the time you should think about myocardial infarction. Clear? Now, acute coronary syndrome or myocardial infarction, also not only the chest pain is the presentation, the other thing that can be associated with that is one is dizziness, another is shortness of breath, another is hypotension or excessive sweating. These are the commonly associated features with MI. Okay, so as in here you can see diaphoresis, tachypnea, anxious expression should alert the clinician to a potentially life-threatening process. most of the time, myocardial infarction patient will say that I think that I'm going to die. This fear of dying is very, very common in myocardial infarction patient. All right. So some of the other physical sign that you can think about, aortic dissection, you should always consider when there is a difference of blood pressure, mainly systolic blood pressure. If it is more than 20 millimeter difference between your both arms and patient having those characteristic chest pain, you should think about aortic dissection. What I said, let's say that systolic blood pressure in the left arm is 140, in the right arm it's 120. So when there is a difference of more than equal 10 millimeter mercury systolic blood pressure in the both arms, that's one of the characteristic finding of aortic dissection. So always think about aortic dissection if there is something like that in the exam. If there is fever with chest pain, think about pneumonia or mediastinitis due to esophageal rupture. Now, some of the other physical signs are important. One is murmur. Obviously, new onset of murmur is important because sometimes patient can have murmur, like new onset of murmur due to a complication of myocardial infarction. Then abnormal heart sound is also important. We'll go through that. If any time you find out there is a S3 gallop, normally S1 and S2 is your normal heart sound. The abnormal heart sound is your S3 and S4. If you get S3 gallop rhythm, that's most of the time that you should think about there could be an underlying heart failure. If you get new murmur, like aortic regurgitation occurs in over half of the patient with aortic dissection. So patient having chest pain, which is central and radiating to the back, and you get a murmur of aortic regurgitation, you should think about aortic dissection. Similarly, mitral regurgitation can happen in myocardial infarction. If you get bivascular crepitation in the lungs, you should think about heart failure. And if it's a new onset heart failure, you should think about it could be a complication of MI causing heart failure. That's also one of the important things you should remember. We'll go through everything. I'll just giving you a basic idea first, and after that, we'll move into the specific diseases. Now, so you know the symptoms now, you know the physical signs. Now, what are the investigations we usually do for cardiac causes? Most of the time, it's your 12 lead ECG is the first or initial test that you need to do in any chest pain. And ECG can be totally normal, or sometimes you can get ST elevation, Q wave, ST depression, T inversion. We will discuss all those ECGs in our ECG class. Sometimes you also do another enzyme called CKMB. Usually this creatinine kinase is usually detectable in your blood after 4 to 6 hours of onset of chest pain, and it gets normal in 2 to 3 days time. Okay. The best enzyme test that we do to diagnose MI is cardiac troponin. And if they give you troponin TIC, what is the best one you do? We usually do the troponin I. Because troponin T or troponin C can get elevated in other conditions, like if you have renal disease, if you have polymyositis, dermatomyositis, that can increase troponin T level. So always, if something confusing like this, they give troponin T, troponin I, always choose troponin I. Any patient with a sudden onset of chest pain with elderly patient should have a ECG first. If the ECG is normal or abnormal, whatever it is, that patient should get a troponin, and obviously at least 2 troponin. Now, the troponin I usually gets abnormal in 4 to 6 hours after starting of your chest pain. The good thing about it that it gets normal in 10 to 14 days time. So you can get troponin elevated even 10 to 14 days after onset of the chest pain. Whereas your CKMB, it starts to rise in the blood in 4 to 6 hours, but usually it gets better in 1 to 2 days. Now, my question to you is that you got a patient and you did CKMB, which was elevated at that time. Okay. And then you also did troponin, and troponin also elevated. Okay. Now, after 7 days, you again, the patient come to you with a chest pain, or patient is already admitted in the hospital, again complaining chest pain. You did troponin, it's elevated, and you also did CKMB, that's also elevated. What you should think about at that time? Do you think it's the ongoing myocardial infarction causing the elevated CK, or is it a new onset MI? It's a new onset MI or reinfarction. So that's the one of the important thing you should think about. If any patient having troponin elevated multiple times, you cannot exactly say is it a new onset infarction or it's a old infarction that's ongoing. So if you want to differentiate between a new onset infarction and an old infarction, at least in between these 14 days, you should do a CKMB. If CKMB is elevated, that you should think about reinfarction. So to diagnose a reinfarction, the best test you do is the CKMB. But to diagnose the MI, the best test is troponin. Clear? Any confusion? Because this is a very important thing. The case scenario I have discussed, that's very, very important to understand. Because that CKMB should not be elevated in 7 days, because it should get normalized in 1 or 2 days. Now, after 7 days, if you still get CKMB elevated, that's most likely again reinfarction. Clear? Good. See this one. If you get normal CKMB level, but elevated troponin level, you should consider that patient might have a minor myocardial damage. But if a patient has both CKMB and troponin elevated, that's acute myocardial infarction. Cardiac troponin may remain elevated up to 2 weeks after the symptom onset, which makes them useful as a late markers of recent acute MI. That means if like a patient can come to you for 4 to 5 days after onset of chest pain. At that time, if you do a CKMB, it will be negative. So you should do a troponin I because it will be elevated at that time. And remember, if they ask you that does the increased troponin I level has any association with mortality of a patient? Yes. If the troponin is very high, the chance of mortality increases. Okay. See this one, those with a normal ECG and a normal troponin I, 6 hours after admission had a very low risk of major cardiac event. So if a patient come to you with a chest pain, high risk chest pain, and you consider that it could be an acute coronary syndrome, you did a ECG, which is normal. You did a troponin, first troponin you did like in 2 hours after onset of the symptom. The troponin came negative. Will you send the patient home? No. What you will do, you will again repeat the troponin in 2 to 4 hours time and also repeat the ECG. If both of them are normal, then usually after 6 hours of onset of the symptom, if everything is normal, after doing a repeat ECG and repeat troponin, then only you can say that this patient doesn't have any MI. The last part is like if you want to be totally confirmed that this patient doesn't have MI, you have to do repeat troponin and repeat ECG, which means that let's say that a patient came to you within 30 minutes or 1 hour of onset of symptom of chest pain. You did a ECG normal. You did troponin in 1 hour time, that's normal. But in 1 hour, patient troponin might not be elevated because troponin it starts to elevate in 4 to 6 hours time. So you cannot totally say that patient doesn't have MI in 1 hour time. So what you need to do, you should at least do a repeat troponin in 2 to 4 hours time. And at that time, like if there is, if the troponin after 6 hours of onset of symptom is negative, then only you can discharge the patient and reassure the patient doesn't have MI. So the borderline point is you have to do repeat troponin, repeat ECG at least up to 6 hours of onset of chest pain. So that's mainly be your troponin and those sort of things. You should have a very good idea on it. And sometimes you need to do a chest X-ray if you think that this is a respiratory related condition. So you might need to think about pneumothorax, pneumonia, pleural effusion. At that time, you should do a chest X-ray. Now, causes of chest pain. We already discussed these important causes. So if it's the aortic dissection, the pain will be sharp, tearing, extremely severe pain, typically radiates to the back. You can have also loss of pulses, or sometimes you can develop aortic regurgitation. If you do a chest X-ray, you will get widening of the mediastinum. Sometimes a patient with aortic dissection can have associated MI also if the dissection extends into the coronary artery. So remember, aortic dissection and MI can be together also sometimes. CKMB, Dr. Samreen, CKMB is not your choice of investigation for myocardial infarction. We, in the hospital or in Australia, in any GP setting, anywhere, we don't do CKMB to diagnose MI. We do troponin after doing the ECG. So CKMB is only you will do if you think about reinfarction. That's the time. Now, for your aortic dissection, obviously those patient comes to you with a chest pain. So initial test will be ECG. After ECG, you can do a chest X-ray, but confirmatory will be transesophageal echocardiogram according to your JM. Okay. Then come to the pulmonary embolism. We will discuss pulmonary embolism later on, but just remember pulmonary embolism always comes with that female patient coming to you with sudden onset of chest pain, shortness of breath, and it's a kind of pleuritic chest pain. And they will give you a history that patient had a long travel history from like Los Angeles to Sydney, like a 12-hour flight. And during that time, patient slept throughout the flight. That's like a long travel history is one of the very important clue for pulmonary embolism. Pulmonary embolism, always there will be pleuritic chest pain and a shortness of breath. And physical signs is very important in here. They will always have tachycardia. That's the most common physical signs in pulmonary embolism. Also, they can have tachypnea. They will have hypoxemia. So saturation of oxygen will go down. For pulmonary embolism, initially, obviously, you will do ECG, and based on the Wells score, we will do those things in the respiratory system. Based on Wells score, we might need to do a D-dimer or we might need to go for a CTPA. Today, we are not going to discuss pulmonary embolism. That's a vast topic. Pericarditis, we already discussed how it comes. Other than those, costochondritis, remember the costochondritis, if you do the chest palpation, the patient will have tenderness in the costocardiac region and the pain also exacerbated with inspiration. Gastroesophageal reflux disease, the pain will be a central burning kind of chest pain. So central chest pain which feels like burning and usually gets worse after lying down and gets better with bending forward. Sorry, so it's no. What happened is that it's a gastroesophageal reflux or esophagitis usually gets lot worse when you lie down and also when you lean forward. Both of these will give you chest pain. And if you elevate the head of the bed, that will relieve the symptom. And reflux pain is usually comes after taking some fatty food, spicy food. That's one of the important clue also. But the specific pain will be burning chest pain and it's central. Peptic ulcer, again, it will be epigastric pain which get worse after eating. Gallbladder disease, not very important for you at the moment. Myocardial infarction, we know, we will discuss more about it. Aortic stenosis, remember aortic stenosis, there is a triad of symptoms, which is one is chest tightness, dyspnea or shortness of breath on exertion, plus syncope or fainting. So syncope, dyspnea, chest tightness with associated murmur in the heart, which is an ejection systolic murmur radiating to the neck, that's aortic stenosis. And it's common in elderly patient. Myocarditis not very important. Pericarditis we discussed. Aortic dissection we discussed. Mitral valve prolapse. See that it's a transient pain common in young female and they will always give you mid systolic click. Okay, so that's these are the some of the characteristics of the pain we need to know. Now we will move into the ischemic heart disease. So for your ischemic heart disease, there are mainly two important subtypes which you need to think about. One, it could be asymptomatic, totally asymptomatic, clinically silent, there is no risk factor. That's not important for your exam. For your exam, symptomatic chest pain is important. So as I said, you divide the symptomatic chest pain into stable angina and acute coronary syndrome. Remember, stable angina, the feature is it's less than like within 10 minutes, the chest pain will be improved with taking rest. So the chest pain, which is the left-sided chest pain, which get worse with exertion or exercise and gets better within 10 minutes after taking rest or after taking a nitroglycerin. Stable angina always comes with exertion. Clear? Now, what if it doesn't get better within 10 minutes? Or what if it doesn't get better with nitroglycerin? And the chest pain, the typical chest pain of myocardial infarction or acute coronary syndrome is left-sided chest pain, which feels like some tightness or heaviness, and it's a severe pain, gets radiated to your left arm, jaw, neck, or sometimes epigastrium, with associated nausea, vomiting, sweating, or sometimes even racing of the heart, feeling dizziness. That's your acute coronary syndrome. The time of the coronary syndrome chest pain, usually more than 20 minutes, doesn't get better with taking rest, doesn't get better with nitroglycerin. So that's your acute coronary syndrome. Acute coronary syndrome divided into unstable angina or myocardial infarction. Now, myocardial infarction has two subtypes, ST elevated MI, non-ST elevated MI. Okay, now look at this picture. This will give you an idea. Let's assume this is your coronary artery and there is atherosclerotic plaque in the coronary artery, but this is not occluded. When it's not occluded, that's most likely it gives you a stable angina or even unstable angina. But when it's get occluded, that's the time we call it myocardial infarction. Okay, now let's move on. So the difference between unstable angina and non-ST elevated MI is that if you look at here, see that this was an atherosclerotic plaque, right? Unstable angina, this thrombus formation or this total occlusion of your blood vessels will not be there. In unstable angina, there will be still something, some of the part of the vessels will be patent in unstable angina. But in non-ST elevated MI or ST elevated MI, there will be some occlusion in the total blood vessels. The difference between unstable angina and non-ST elevated MI can only be diagnosed by doing the troponin. Otherwise, there is no way we can differentiate between an unstable angina and non-ST elevated MI. The symptoms are same, everything is same. Okay, and ECG is also same. In unstable angina or non-ST elevated MI, in the ECG, you might not get any finding, or you can get ST depression or T wave inversion. So this is your P wave. This is the QRS complex. And then your T wave. So P wave, then this is the QRS complex. This is the ST wave. And then this is the T wave. When it is unstable angina or non-ST elevated MI, you can get ST depression like this. Okay, so this is the baseline. This baseline can come down, which is ST depression. It can be like this, it can be like this. So this is ST depression, or sometimes the T wave can get inverted like this. So if you get T inversion, ST depression, you should think about unstable angina or non-ST elevated MI. Now, how you differentiate between these two? If you do a troponin and troponin is elevated, that's MI. If troponin is negative, that's most likely unstable angina. Clear? And what is the difference between ST elevated MI and non-ST elevated MI? So both MI, ST elevated or non-ST elevated MI, their troponin will be raised. Troponin raised means it's MI. Now, is it a ST elevated MI or non-ST elevated MI? That depends on the ECG finding. In the ECG, if you get like this, okay? Now, what you see, this is the baseline. Your ST segment should be here, right? Now, ST segment go up like this. So now this is the ST elevation. So if you get ST elevation with raised troponin, then we call it ST elevated MI. Clear? So this is the main difference between these three things. And both this unstable angina, non-ST elevated MI, ST elevated MI, all together they are called acute coronary syndrome. Any questions so far? Those who are in the Facebook, any question? That means that when it becomes MI, that means it's causing necrosis or infarction of the area of cardiac muscles which is supplied by that particular coronary artery. When there is infarction or muscle death, it becomes MI. When there is still a little amount of blood flow, it's not infarction or necrosis of that particular muscle, then it could be unstable angina. Any question, guys, so far? Okay, so Dr. Joe Matz, the difference between stable angina and acute coronary syndrome is that stable angina, the onset is always related to physical exertion, and the time period of the chest pain is less than 10 minutes. And usually it gets better with taking rest or taking nitroglycerin. And also ECG finding will be normal, troponin will be normal, everything will be normal. That's your stable angina. No, Dr. Mimu Ghosh, unstable angina never ever causes elevated troponin. That's how you differentiate between unstable angina and non-ST elevated MI. Okay, Now we move on. This is very important to understand, and that's the basic of your myocardial infarction. You should always understand how you can differentiate between these three conditions which mimics with each other, because all of them will present to you with a chest pain. Who will be MI, who will be angina? That's important to understand. Now, what are the major risk factor which causes this myocardial infarction? The single most important risk factor is your elevated cholesterol level, which is mainly elevated LDL cholesterol. Okay, that's the most important subgroup that carries the risk of ischemic heart disease. And the worst risk factor which causes complicated MI, that's your diabetes mellitus. The question will ask you, what is the single most important cause of MI? Single most important cause of MI is elevated cholesterol, hypercholesterolemia, or dyslipidemia. Same thing. What is the worst risk factor? Diabetes mellitus. What is the most common risk factor? Hypertension. But the single most important risk factor, or if they ask you that what is the most common risk factor or what is the most important risk factor for having a MI, always choose hypercholesterolemia. So there is, in your handbook, there is a question similar like this. So they ask you, which one of the following carries the most important risk factor to have MI? Most important is your hypercholesterolemia. And another question is, what is the most important risk factor causes stroke? Mainly your hemorrhagic stroke. What is the most common cause or most common risk factor of a stroke? Hypertension. Good, Dr. Arafat. So this is the two important thing you should remember. It's sometimes they usually ask this sort of question in the exam. Now we'll go through some of the question. A 48-year-old woman comes to the office with chest pain that has been occurring over the last several weeks. So it's not an acute onset. And it's a 48-year-old woman. The pain is not related to exertion. The location is retrosternal. Pain sometimes associated with nausea, no shortness of breath. Pain doesn't radiate beyond the chest. No past medical history. Now, remember one thing. Before menopause, in a woman, having myocardial infarction is very unlikely because the estrogen gives the support, or estrogen usually prevent the MI in the women before 50 or before menopause. After menopause, the chance of MI increases in women. This is a 48-year-old woman, and you see that it's not an acute onset, and chest pain is not related to exertion. That actually exclude your unstable angina, that exclude mainly all cardiac causes. And also you can see it's a retrosternal. Retrosternal means central. So central chest pain in a woman, not related to exertion, occurring over several weeks, doesn't radiate, and no shortness of breath. So very unlikely to be anything which is serious. So most likely it's a gastroesophageal reflux disease. If it was pericarditis, the chest pain will be sudden, severe, acute onset. Pneumothorax, also acute onset. Obviously, there will be shortness of breath in pneumothorax. Prinzmetal angina, again, the chest pain will not be retrosternal and it will be also acute onset. We'll discuss what is Prinzmetal angina later on. So this is one of the important thing. If a 48-year-old woman had chest pain with no risk factor, it is very unlikely that it is ischemic heart disease, because the estrogen usually gives the support and it's a protective effect for women not to get ischemic heart disease before menopause. So menstruating women virtually never ever have myocardial infarction. That's one of the important tip, unless they don't have any risk factor. Now, Dr. Arushi, why it's not a stable angina? Even if it was there was the option of stable angina, are you going to choose it? No. What is a stable angina? The chest pain which get worse with exertion. They have given you, it's not related to exertion. So it's not a stable angina also. We already discussed which one of the following is the most dangerous to a patient in terms of risk for coronary artery disease. So most dangerous in terms of risk factor is elevated LDL. Now there is a condition called Tachycebo Not very important for your exam, but obviously I would say go through it at least. So the question is like that: a postmenopausal woman develops chest pain immediately on hearing the news of her son's death in a war. She develops acute chest pain, dyspnea, and ST segment elevation in lead V2 to V4. Elevated levels of troponin confirm an acute MI. Now you see in here that what is MI? Myocardial infarction means, so if it is your coronary artery, so this is right coronary artery, this is left coronary artery, let's just assume, and these are the branches. So obviously if it is MI, one of the big coronary arteries is totally obstructed, right? So in here, you have got the typical ST segment elevation, you have got elevated troponin. So you should obviously think it's an acute myocardial infarction, which is ST elevated MI. Now to confirm that, you did a coronary angiography, which is normal, including an absence of vasospasm on provocative testing. Absence of vasospasm exclude prinzmetal angina because prinzmetal angina is nothing but a vasospasm of the coronary arteries. And coronary angiography is a test where you put a dye and that dye reaches the coronary vessels to show how much obstruction of the coronary arteries is there. Now, if there is no obstruction in the coronary arteries, it cannot be myocardial infarction. So what is the other condition which gives you the total features of MI? That's one of the condition called Tachycebo How you confirm it? Doing an echocardiogram, which will reveal apical left ventricular ballooning. So the left ventricle becomes ballooning like this. So Tachycebo it's an acute myocardial damage, usually occurs in postmenopausal women immediately following an overwhelming, emotionally stressful event. Like it could be divorce, financial crisis, lightning strike, anything. And that leads to ballooning and later on left ventricular dyskinesis, which means left ventricular wall movement gets abnormal. So, and that's lead to the myocardial infarction kind of features and symptom. But you can get elevated ST elevation, you can get increased troponin, but coronary angiogram will show no ischemia. If coronary angiogram shows there is no ischemia, it cannot be myocardial infarction. So only other one remains is the Tachycebo. The management is beta blocker and ACE inhibitor. Not very important, but it's still you should remember if they give you something like that, you should think about Tachycebo. Correcting which of the following risk factor will result in the most immediate benefit for the patient. The most important reversible risk factor for this coronary artery disease is smoking. So if you stop smoking, it will give immediate benefit. Just to remember. Now we discussed this flow chart already. Like if any patient presents to you with acute coronary syndrome, like features, you do a ECG. If ST elevated if there is ST elevation, see this is the baseline. Now this ST segment is elevated. So if ST elevation, it's a ST elevated MI. For ST elevated MI, the next important management is to send the patient immediately to the catheter lab, okay, to dissolve the clot or to remove the clot, which is your percutaneous coronary intervention, or we call it PCI, or you can call it angioplasty. So ST elevated MI will obviously go for percutaneous coronary artery intervention. That's the main management. Apart from PCI, we also need to do monotherapy. What is monotherapy? Monotherapy is morphine. So this patient has a severe chest pain. So you have to treat the chest pain. So give morphine for chest pain. Oxygen, if saturation is less than 94%. Nitroglycerin and aspirin. Among these four, which one is the most important management you should give to a ST elevated MI patient? Aspirin. Okay, the most important is your aspirin, and among all these three things, aspirin improves the mortality of the patient. So only thing which improves the mortality or decrease the mortality is aspirin. So aspirin is the vital thing you should always think about in any case of MI. Others will not increase, is like others will not decrease the mortality. So there is no mortality benefit for these three, but mortality benefit is aspirin. It's a must thing to do. Clear? So that's important to remember. Any chest pain which seems to be MI, you should give aspirin even without a diagnosis of ST elevated MI. So you think that a patient come to you with a chest pain, sudden onset, middle age, give aspirin, and then you do everything. Because every second there is cardiac death occurring. And if you give aspirin, that cardiac death will be prevented. And you can save that patient life just by giving that aspirin. Now, if there is no ST elevation, then the next thing you do is the cardiac marker. So cardiac marker is mainly troponin. If troponin negative, it's unstable angina. If troponin positive, it's a non-ST elevated MI. For non-ST elevated MI, there is no indication of giving percutaneous coronary intervention. The non-ST elevated MI is not a full thickness MI. It's called subendocardial MI. Okay, so the subendocardial MI, it's a partial thickness MI. So it's still like most of the part of the vessel is occluded, but it's still a little bit is there, or like the upper part of the atherosclerotic plaque has been dislodged, and there is still a little bit of flow is going on, but it's not enough to save the cardiac muscle. That's called subendocardial MI. For subendocardial MI, there is no ST elevation in the ECG. That's your non-ST elevated MI, and your management doesn't include percutaneous coronary intervention. The main management of non-ST elevated MI, obviously aspirin should be there, but next thing that you think about is to give heparin, low molecular weight heparin, to prevent formation of any further clot, because it's still there is something left to be occluded. Now, if you don't give heparin, might be that small part can get occluded, and that non-ST elevated MI can change into ST elevated MI. So you need to give heparin to this patient. Clear? Now, obviously, the worst prognosis is in the ST elevated MI rather than unstable angina or non-ST elevated MI. See this line, thrombolytic therapy is your PCI, or sometimes you can also think about streptokinase, those sort of things. So thrombolytic therapy is beneficial in patient with only ST elevated MI, but not effective in unstable angina or non-ST elevated MI. Clear? So not all MI patient gets thrombolytic therapy. Characteristics of ischemic chest pain we already discussed, not needed. You can go through this later on. Now, some of the other causes, this is from your MTB or master the board. If you anytime see there is chest wall tenderness, think about costochondritis. If there is the chest pain radiation to the back and there is unequal blood pressure between arms, aortic dissection. Pain which works with lying flat, better with sitting up, pericarditis. When there is epigastric discomfort and pain associated with eating, duodenal ulcer, and others like pulmonary embolism, pneumothorax, pneumonia, we already discussed, not very important to go through now. Now, I'm not going into the total management of MI at this time. I'll go into detail again after a few minutes. Before we go into detail of the MI management, sometimes if it's not a myocardial infarction, it's just an unstable angina, what are the investigation you should do to help that patient so that that patient doesn't get MI later on? What if a patient comes to you with a stable angina? All right. So like a stable angina patient, and you have done the ECG, which is normal. You have done the troponin, which is normal, but that patient has cardiac risk factor like hypertension, family history of MI, or patient smoker, or patient has hypercholesterolemia. So these are the risk factor of getting MI. In those patients, you need to do further testing to find out that if this patient can can be managed before MI happens. So what are the tests that you do? The next test you do after, like, usually you can discharge the patient, and then in the outpatient department we can do exercise stress test. So these are called stress test or ETT, which is called exercise tolerance test. It's a very important test to evaluate that if this chest pain is related to coronary artery disease. So your ECG is normal, and but still there is a risk factor of coronary artery disease. Then the next thing you do is order a exercise tolerance test. Obviously, before you order exercise tolerance test, you have to see that if this patient is able to do exercise or not. All right. Now, see this one, ETT is based on two factors. You can read the EKG or ECG, and you can, and the patient can exercise. Only these two cases you will do ETT. What if you cannot read the ECG? Why? Because there is some baseline ECG abnormality already there. Like there is some ST depression, or there is T inversion, or there is a left bundle branch block. At that time, doing a exercise tolerance test doesn't help. So if there is a baseline ECG abnormality, then you order either nuclear isotope scan or a echocardiogram. The nuclear isotope intake uptake or scan, usually we call it thallium scan. And also we can do echocardiogram. What are the baseline ECG abnormality you should look for? If there is left bundle branch block, if the patient already on pacemaker, then ECG will not give you any finding. If the patient is on digoxin, also it will have a baseline abnormality, or if the patient has left ventricular hypertrophy. So any patient having left bundle branch block, LVH, pacemaker, digoxin, those patients you cannot do ETT. You have to think to do either thallium scan or echocardiogram. How thallium scan help you to find out acute coronary disease? Normal myocardium or heart muscle usually should pick the nuclear isotope. If any part of the myocardium is not taking the isotope, then you should think that that part might have some abnormality or that part is ischemic. So that's why you do a thallium scan to see if the whole myocardium equally uptaking the thallium scan or not. Clear? That's your thallium scan. Help you to understand that if any part of the myocardium is ischemic or not, or having decreased perfusion or not. Because like see that this is a heart, this coronary artery is totally fine. There is no atherosclerotic plaque. But this coronary artery having 50% block. So obviously this cardiac muscle will not uptake nuclear scan similar like this muscle. This muscle will take more than this muscle. This is how you can say that, well, most likely there is some occlusion in this coronary artery. That's why this muscle is not uptaking enough isotope. Okay, that's how you can find out. And in echocardiogram, what you will look for? You will look for myocardial wall motion. Normal myocardium usually will move with each contraction or each pumping of the blood. If any time any part of the myocardium is not moving normally, which we call dyskinesia or regional wall motion, or we can call hypokinesia, akinesia, that means that myocardial wall is not moving like a normal myocardium. That also gives you some understanding that this part of the heart is not getting enough blood. I know this is a little complicated and you should never ever go in this much detail, but in the exam, sometimes they ask about indication of thallium scan, echocardiogram. So you should know this thing. So when you do a thallium scan, when you find out that this patient is high risk chest pain, but ECG normal, troponin normal, everything is normal, then you should do a either exercise tolerance test or this thallium scan or echocardiogram. If baseline ECG is normal, you go for exercise tolerance test. If baseline ECG has some abnormality like left bundle branch block, patient having left ventricular hypertrophy, pacemaker, then you go for thallium scan or echocardiogram. Now, the next thing, what if the patient cannot exercise? Which means that your patient doesn't have any baseline ECG abnormality. So obviously you should be able to do a exercise tolerance test. Now your patient is not able to exercise, maybe patient having fracture or patient having underlying knee joint problem, hip joint problem. Okay, so the exercise tolerance test, patient needs to run in a treadmill. So those patients will be unable to run in a treadmill. So for those patients, you have to do chemical stress testing, which means you can give some medication which will stress the heart or which will cause the similar effect on the heart if you would run on the treadmill. That is called dobutamine or dipyridamole stress test. Usually we do this dobutamine stress test, which means that you will give dobutamine to the patient and dobutamine will cause the same stress on the heart as if you are running on the treadmill. So dobutamine will increase the myocardial oxygen consumption and provoke ischemia if there is any ischemia in the heart. Usually we call it dobutamine stress echocardiogram because you need to do a echocardiogram and give the dobutamine in this patient. So these are the all the tests that you do for this sort of patient who doesn't have any ECG problem or raised troponin, but high risk chest pain patient. For high risk chest pain patients, first thing to consider is exercise tolerance test. For exercise tolerance test, we need to think that the ECG is totally normal, there is no baseline abnormality, and patient is able to exercise. If patient is not able to exercise, then you go for dobutamine echocardiogram. Or you can also think about dipyridamole thallium. Both is more or less same. Usually those patients who cannot do exercise, you can use either dobutamine echo or dipyridamole thallium. What if there is underlying ECG abnormality, like left bundle branch block? You cannot do ETT, you do a exercise thallium scan, or you can also do exercise echo. Clear, guys? So any patient having baseline ECG abnormality, you cannot do exercise tolerance test. You need to do either thallium scan or echo when the patient is doing exercise. If patient unable to exercise, you should do a chemical stress echocardiogram. Chemical stress echocardiogram is this one, dobutamine echo. Any question, guys? If you have any confusion, ask it now, because this is one of the important thing which you will get really, really complicated. Any question on this stress test? Okay. Yeah, dobutamine and dipyridamole, these are same thing, just the different chemicals you are using. See, if I give you a chart like this, let me ask you a question so that you guys understand it really. Let me see if I can get, okay. So let's say that you have got a patient who is high risk chest pain, like a 40-year-old man having hypertension, hypercholesterolemia, having on and off chest pain, ECG normal, troponin normal. Now, this is a high risk patient. What you are going to do next? You will look into the ECG. Now, ECG doesn't have any baseline abnormality. So ECG, no baseline problem. What is the next thing you will do? You will check if the patient can do exercise or not. If patient can do exercise, then patient will go for exercise tolerance test. What if this patient cannot exercise? What is the next thing you will choose? You cannot choose exercise tolerance test. So what you can choose? Yes, then you will choose dobutamine stress echocardiogram. Okay. So you are going to choose the dobutamine stress echo for this patient, or also dipyradamal thallium scan you can do. Now, this patient having ECG abnormality, then you cannot do ETT, you cannot do dobutamine stress echo. So what is the next thing you can choose for this patient? If there is a baseline ECG abnormality, then only thing that you can do is the thallium scan, or also you can choose echocardiogram while the patient doing exercise. So exercise echo or exercise thallium scan. Clear? Now it should be totally fine. I haven't understood your question, Dr. Victoria. What about a pregnant woman with pregnancy superimposed hypertension? What is your question about? For pregnant women, it's better not to do exercise stress. We'll go for the echocardiogram. Good. Let's move on. See this question. A man with atypical chest pain is found to have normal nuclear isotope uptake in the myocardium at rest. On exercise, there is decreased uptake in the inferior wall. 2 hours after exercise, the uptake of nuclear isotope returns to the normal. What is the right thing to do? What does it mean? It means that when the patient doing exercise, there is some ischemia in the inferior wall, which means that this patient having stable angina, right? So this sort of patient gets the most benefit from a angiography. What is angiography? Angiography means that it will give you the exact percentage of stenosis or narrowing of the coronary blood vessels. So you see this one, this patient has reversible ischemia on the stress test. This is exactly the person who needs angiography. Now, when you do the angiography, if the angiography gives you that this patient having like single vessel disease or triple vessel disease, like angiography will show you like 80% stenosis or 50% block in the right coronary artery or 80% block in the left coronary artery. So it will give you an idea that how much blockage is there in the coronary artery. And sometimes based on that, you can offer either angioplasty, so putting an stent into the coronary artery to keep the vessels patent, or sometimes we might need to go for a bypass surgery if the patient mainly have triple vessel disease. That means all the three major coronary vessels are blocked. That patient needs CABG or CABG. So angiography will determine who needs bypass surgery, who needs angioplasty. So angiography is the most accurate method of detecting coronary artery disease. So coronary angiography will give you the exact finding that how much blockage is there. So confirmatory test is angiography. Stenosis less than 50% is insignificant and surgically correctable usually when becomes more than 70%. So more than 70% blockage is significant. Those patients will need either angioplasty or bypass surgery. Now look at this chart, very important, and it will give you the whole idea of management of this sort of patient. So you have got a patient with a chest pain and high risk chest pain patient. You do the ECG, the resting ECG, that means when the patient's resting, you did the ECG, and that ECG was not abnormal. So resting ECG was normal. If resting ECG normal, then what do you think? You think about doing an exercise tolerance test. Now, to do exercise tolerance test, patient needs to do exercise. So you need to think, is this patient able to exercise? Is this patient is able to exercise? Yes. Then you do the exercise stress test. If not, then you go for chemical stress test, which is the dipyradamal or dobutamine. Any of these stress tests showing reversible ischemia, you do a angiography. Now, with the angiography, if it shows one or two vessel disease, which means one or two vessel having more than 70% stenosis, that patient gets benefited from doing a stent placement, which is angioplasty. If three vessel disease or patient having the left main coronary artery disease with diabetes, that patient needs CABG. Just remember, three vessel disease needs bypass, one or two vessel disease needs angioplasty. So this is the basic thing that you should know, because anytime any type of question can come from the these chest pain things, because these are very important topic. Is this clear, guys? So this is not for acute myocardial infarction. This is actually for reversible ischemia patient, which is mainly stable or unstable angina patient. Now there is another investigation which we call Halter monitoring. Halter monitoring also is a very important, comes in the exam many times. Halter monitoring, it's a continuous ambulatory ECG monitoring for 24 hours. So 24-hour patient will have the ECG attached to their body, and they will, most importantly, they can detect any rhythm disorder like any atrial fibrillation, flutter, ectopics. Remember, Holter monitoring doesn't detect ischemia, and we don't do Holter monitoring to find out if this patient is having MI or not. One of the very important or common mistake that candidate do is choose Holter monitoring for MI. Remember, Holter monitoring is only for those patients who has rhythm disturbance. Like a patient coming to you with feeling dizziness, and you did ECG, nothing came up. Because at that time, when you did the ECG, it was normal, or patient did not have any rhythm disturbance. But you put the patient on Holter monitoring for 24-hour ECG, and at one point, this patient you can see is having heart block. And that explains why this patient is having frequent dizziness or syncope. So to find out these underlying rhythm disorders, we do the Holter monitoring, which is a 24-hour ECG monitor. Now, the most important things will start from here, how we manage acute myocardial infarction patient. Are you still with me, guys? Are you understanding what I am teaching you? You guys are getting it? Or do you think it's very complicated? I'm trying my best to make it as digestible as possible. Yeah, Dr. Jarin, there is two type of it. The BP, there is no BP halter, that usually we call it ambulatory BP monitoring. It's not halter mainly. So there is one is ambulatory BP monitoring, that's 24-hour BP monitor. And halter monitoring is mainly 24-hour ECG monitoring. It's separate. But you know, like the Holter monitor gives you everything. It gives you ECG, it gives you blood pressure, pulse rate, it gives you saturation, everything. Like means total vitals you can see if you put the patient on the Holter monitor. But the name if you want to use ambulatory 24-hour BP monitoring, that's a different thing. Usually you use it for high white coat hypertension patient or frequent changed hypertension patient. You do the 24-hour ambulatory BP monitoring. You don't do 24-hour ECG monitor for those patients. We'll go into that when we'll discuss hypertension. Okay, now let's start this thing because it's very important for your exam and many candidates get it wrong. And these are mastery questions. You should not get it wrong at all. A 48-year-old woman comes to the office with chest pain that has been occurring over the last several weeks. The pain is not reliably related to exertion. She is comfortable. Location of the pain is retrosternal. She has no hypertension, ECG normal. What is the most appropriate next step in management? Now, for this patient, what you should do? You see that this is a 48-year-old woman having chest pain occurring over several weeks, pain not related to exertion, retrosternal. Your option is doing a CKMB, troponin, echocardiogram, exercise tolerance, angiogram, CT angio, cardiac MRI, Holter monitoring. What do you want to exclude in this patient? You know that this patient might have gastroesophageal reflux, but still you cannot totally be sure without you do further investigation. So what do you want to do in this patient? So you need to do a exercise tolerance test only, but because this patient is having a lot of chest pain over several weeks and patient doesn't have any baseline ECG abnormality. No, nothing has written that patient cannot do exercise. So the next appropriate thing is to just to see that if this woman having any reversible ischemia or not. So you do a exercise tolerance test. That is the reason I actually discussed a lot about this thing, because sometimes we might need to choose this option. See, enzymes are to evaluate acute coronary syndrome, but our patient having the chest pain for several weeks. So you don't need to do CKMB or troponin for this patient. And also, exercise tolerance test is not used in acute coronary syndrome in which patient is currently having pain. So also don't put patients on a treadmill to exercise if they are currently having chest pain. So any patient having chest pain at the moment, you should not do ETT. But our patient is comfortable now. So that's why we're doing a ETT and in this patient. We don't need to do echo, troponin or CKMB in this patient. All right. Now, what are the general management for these patients? General management for any patient having stable or unstable angina is you give aspirin to all these patients unless contraindicated. And when you do ETT or any of those stress tests, if they show reversible ischemia, you should go for angiogram. And if angiogram shows more than 70% stenosis, then you go for either bypass or stenting. That's mainly the management. Some of the patient also should be started with clopidogrel. So most of the patient usually gets benefited from bi or in like dual antiplatelet agents, which is aspirin or clopidogrel. And also for the patients who is having mainly your non-ST elevated MI, we also go for heparin or subcutaneous enoxaparin. We'll go through this management again because this is not the complete management in here is written. So we'll go through that again with you. Let's go in this question. 70-year-old woman comes to the emergency department with crushing substernal chest pain. So crushing pain in an elderly, obviously, it could be acute MI for the last hour. And ECG shows ST elevation in V2 to V4. So it's a ST elevated MI, most likely. What is the most appropriate next step in the management of this patient? So now see that there is obviously in your exam, there will never ever be this much option, 5 option. So, but from here, everything a patient needs for a cardiac management, these options are there, CKMB, oxygen. But what do you think in a patient who is having ST elevated MI, what is the next step in management for this patient? Now, obviously, you can think about doing and giving a morphine first, but remember, for any patient having cardiac chest pain, that is the only time you should think about giving aspirin first. And just after giving aspirin, you should send this patient as soon as possible to the catheter lab for PCI. So the next option should be aspirin. As they ask next, it should be aspirin first. See, the answer is D. So aspirin lowers mortality with acute coronary syndrome, and it's critical to administer it as soon as possible. With only 1 hour since the chest pain, neither your CKMB or troponin will be elevated. You can obviously give morphine, oxygen, nitroglycerin, but they don't lower mortality rate and not important as aspirin. Aspirin should be given simultaneously with activating the catheterization lab. So give aspirin, call the catheter lab to start the initiation of sending the patient to the lab for PCI. So patient should be transferred to the ICU, but always initiate the aspirin before you send the patient to the ICU or send the patient to the catheter lab. Now, when you send the patient to the catheter lab, not all hospital has catheter lab. In such situation, you should think about that what is the most beneficial for this particular patient. For thrombolyte, like to dissolve the clot, you can either do angioplasty, which is putting the stent and removing the clot. That's only present in tertiary hospital, not in rural hospital. So in rural hospital, you should not think about sending the patient to the catheter lab. In rural hospital, it's better to initiate thrombolytic therapy, which is your streptokinase, altiplase, retiplase, those sort of thrombolytic agents. So if it's a rural setting, in rural setting, we should initiate thrombolytic rather than delaying and referring the patient to the tertiary hospital. So rural thrombolytics. But if a patient is in the tertiary hospital, if it is less than 12 hours of onset of chest pain, that patient should get PCI. And ideal is to get the PCI within 90 minutes of presentation to the hospital. That's the maximum delay you can do. Clear? But the maximum time period is 12 hours. Remember, in your JM, it's a little confusing that they have written in a way, it seems like that within 90 minutes, you have to go for angioplasty. After 90 minutes, you cannot do angioplasty. It's not like that. The ideal thing is doing angioplasty within 90 minutes of presentation to the hospital. But up to 12 hours of onset of chest pain, you can do either angioplasty or thrombolytics. Thrombolytics if patient is in rural hospital, angioplasty if patient is in tertiary hospital. But after 12 hours, you cannot do thrombolytics or you cannot go for angioplasty. Only thing that you can do at that time, just give the low molecular weight heparin. The good thing is, Dr. Tuba, if a patient has ST elevation and chest pain, which is like cardiac chest pain lasting more than 20 minutes, the the next thing is you even don't need to do troponin to confirm the diagnosis, because if it's ST elevation and there is chest pain in a patient which is high risk, that is obviously a ST elevated MI. The good thing is to go for aspirin and send the patient to the catheter lab. In between, you can do troponin, but that's not your highest priority. Your highest priority is giving aspirin and initiate catheter lab. So we have been discussing this management. So again, remember one thing, let me write it so you will understand much better. So first of all, if you get a ST elevated MI, then the next thing you should think about, obviously give aspirin as soon as possible. And then this patient needs to go for catheter lab for PCI, which is angioplasty. Angioplasty only if it is a tertiary hospital and patient presents less than 12 hours of onset of symptoms. What if it's a rural hospital, ST elevated MI, and patient presented to you less than 12 hours? Then you can go for thrombolytic therapy, which is your this streptokinase, altiplase, retiplase. Anytime if it is more than 12 hours, you cannot do thrombolytics, you cannot go for PCI. That's already delayed. The clot has already become very hard. If you go for thrombolytics or PCI, the most likely chance that patient will bleed heavily, or you can even rupture, or you can do damage to the coronary artery permanently. So that's the reason. So below 12 hours, ST elevated MI, you can think about PCI or thrombolytic. If rural, thrombolytic. If tertiary, PCI. Is this clear for everyone, guys? Good. Great. This is the most complicated part where candidates get really, really confused and they choose wrong options in the questions. Now let's move on. What if it's not a ST elevated MI? What you will do next? If it's a non-ST elevated MI, that means patient has ECG normal but troponin elevated, which means non-ST elevated MI. In non-ST elevated MI, there is no indication of doing thrombolytics or PCI. For those patients, obviously aspirin is must, and after aspirin, you can give heparin, low molecular weight heparin, to prevent further clot formation. Remember, heparin doesn't dissolve clot, it prevents further clot formation. See this one, a 70-year-old woman comes to the ED with crushing chest pain. ECG shows ST segment elevation. Aspirin has been given. What is the most appropriate next step? What do you think your next step here? CKMB, oxygen, nitroglycerin, morphine, thrombolytic, atorvastatin, angioplasty, troponin, lisinopril. Remember, for cardiac or for acute ST elevated MI, don't think about giving morphine, nitroglycerin or anything after aspirin. Go for angioplasty. See the option, angioplasty is associated with greatest mortality benefit of all steps. All the answers are partially correct because all of them should be done for the patient. But again, morphine, oxygen, nitrate will be given to the patient immediately, but they don't clearly lower mortality. The best thing to do is to send the patient to the catheter lab as soon as possible. Okay, so for this particular ST elevated MI, always think your next step is giving aspirin, and then next step is angioplasty or initiation of the catheter lamp. Next question, a man comes to the ED with a chest pain for the last 1 hour that is crushing and doesn't change with respiration. ECG shows ST segment depression in lead V2 to V4. Aspirin has been given. What is the most appropriate next step in the management of this patient? Now, next appropriate would be checking the troponin level, but that's not in the option. So what you can choose from here, for this patient is better is your low molecular weight heparin. So heparin will prevent a clot from forming in the coronary arteries. It doesn't dissolve clot that is already formed. So when the patient has acute coronary syndrome but no ST elevation, there is no benefit of thrombolytics. Okay, so in that case, we will go for the low molecular weight heparin. Now, sometimes we may need to use this apiximab, tyrofibin. What are those agents? These are also antiplatelet agents. Usually we use these agents for patients with acute coronary syndrome who are going to have angioplasty and stent. But you cannot do it for patient with acute ST elevation infarction. Not very important, just remember they are not beneficial in acute ST elevation infarction, separate from those of angioplasty and stenting. The main thing is that remember those patients who has unstable angina, and if that patient needs angioplasty and stenting, these are elective, not emergency. For those patients, because if you use clopidogrel, aspirin, they can increase the bleeding during this angioplasty stenting. For that reason, don't use clopidogrel in those patients. You can use this glycoprotein for those patients before angioplasty and stenting. Not important. So these are the summary of what are the medication we can give. You can just have a look, not important. We already discussed everything. Remember one thing, for ST elevated MI, you are doing urgent PCI or urgent angioplasty. Some of the patient with non-ST elevated MI can get benefited by invasive management, but you don't need to do it as urgent like ST elevated MI. What you can do, so within 48 hours of non-ST elevated MI, you send the patient for coronary angiography to see how much obstruction in the coronary arteries. Depending on that, if there is high risk, because now the patient having non-ST elevated MI, if you don't treat this patient or if you don't remove the clot, that clot can get superimposed with other clot and then it can turn into ST elevated MI later on. So better for those patients. Obviously, heparin will help to prevent formation of further clot, but it's not 100% effective. If it is high percentage of obstruction or block in the coronary artery, that patient will also get benefited with angioplasty, but that are not emergency like ST elevated MI. Remember, there is a condition called silent MI. Silent MI is patient might not have any chest pain, but still there is ST elevation in the ECG, there is raised troponin. That's called silent MI. It's mainly positive in diabetic patient because diabetic patient has neuropathy. They might not understand or feel the chest pain. Clear? So that's also one of the entity you should remember. So we already discussed patient with ST elevated MI who present within 12 hours of onset of symptom should have a reperfusion strategy, either thrombolytic or PCI. Patient presenting with non-ST elevated MI will not benefit from thrombolytics. Okay. Now, what are the typical ECG changes in a patient with ST elevated MI? Remember, immediately what happened is hyperacute T wave. So there will be like this PQRS. Then there is like this is called hyperacute T wave. That means tall peak T wave. Then after the hyperacute T wave, then you have ST segment elevation. Okay. And just 1 to several days later on, then you develop Q wave, and then in 6 to 24 hours, T wave inversion. So first hyperacute T wave, then you develop ST segment elevation, then you develop Q wave, then T wave inversion. This is how the evaluation of ST elevated MI occurs. All right. So we'll go through this again. We'll take it now, and then we'll finish this cardiac chest pain. All right. So don't, we are not finishing. There will be half an hour class again after the break. So, and then we'll finish this lesson. Okay. So 10-minute break. Thank you. If you have any question, you can write it in the comment box or in the Zoom chat box. Thank you. All right, everyone. So let's start again. Just give me a second. Okay. So we have been discussing about the myocardial infarction, and we have been discussing about how the ECG can change gradually, right? Normally, it's very important. Sometimes they ask you that what is the immediate changes of ECG in a patient with a still elevated MI. So that's a very important thing you should always remember. We already discussed that when we should do the emergency reperfusion therapy, which is the best one is the PCI, and only when patient presents within 12 hours of symptom onset, then we do the PCI. Whenever PCI is delayed or not available, then we go for the thrombolytic therapy. Thrombolytics is usually the streptokinase, or you can use tissue type plasminogen activator. These sort of things usually lies the clot, and then usually it improves the survival also. Also, the greatest benefit for thrombolytics if a patient presents to you within 12 hours of onset of symptoms. After 12 hours, we don't go for thrombolytics or PCI. Now, before you consider thrombolytic therapy for anyone, you should look for some of the important thing that if this patient is having any contraindications to the thrombolytic therapy. Most important complications is if the patient has active bleeding or bleeding disorder, if patient had a head injury or any trauma to the head within 3 months, if the patient is a suspected aortic dissection, patient had ischemic stroke within 3 months, or if the patient had prior history of intracranial hemorrhage. This patient should not go for thrombolytics because then increased chance of bleeding is there. Late presentation, if the patient presents more than 12 hours after symptom onset, then usually neither PCI or thrombolytics is routinely recommended. So what are the different complications that can happen in a patient with myocardial infarction? That's also important to know. One of them is sometimes in a patient with myocardial infarction, if the myocardial infarction also causes involvement of the papillary muscle, then the papillary muscle can rupture. With papillary muscle rupture, that patient can develop mitral regurgitation. Sometimes they can also develop ventricular wall rupture. That's not very important. It's not very commonly happen, but these are the important complications that can happen. Sometimes even after one ischemia, patient can develop another ischemia, which we call post-infarction angina. If any patient after getting thrombolytics or PCI again develop post-infarction angina, that patient needs to be treated with bypass surgery. There is another important complication called Drizzler syndrome. Drizzler syndrome is nothing but pericarditis after MI. So if a patient comes to you who had a recent MI and now the patient complaining chest pain, which is similar to pericarditis, that's called Drizzler syndrome. Treatment is aspirin NSAID and a steroid if there is no response. And what is the most common cause or of sudden cardiac death after a MI? That's very important, comes in the exam. That's called ventricular fibrillation. I said that we'll discuss about Prince metal angina. The Prince metal angina or variant angina is also present to you just like how the MI patient presents. The pathophysiology is in here, there is no clot which block the coronary artery. In here, it's a constriction or spasm of your coronary arteries. Due to constriction or spasm, there will be lack of blood flow to your myocardial muscle, and it can also cause ST elevation in the ECG. Although these episodes terminate spontaneously, sometimes prinzmetal angina can be associated with acute MI as well. Now, as a opposed to the typical angina, that's the only one thing that will help you to differentiate between MI and prinzmetal angina is that prinzmetal angina usually occurs when the patients are in rest, most often at night or early morning hours. Okay, so if chest pain occurs during rest, that's most of the time it's not MI. Okay, that's only thing you need to think about. And also remember, this patient will have ST elevation in the ECG. You may think it's the acute MI. Now, then you do exercise test and routine coronary angiography, that will come as normal because it's just a spasm. If you do coronary artery provocation test, which we do by giving argonovin. Usually argonovin causes vasospasm. Now, if you give argonovin, then it will trigger coronary spasm, and that's confirmatory for diagnosis of prinzmetal angina. As it's a spasm, you need to dilate the coronary artery by some coronary dilator. What dilate coronary artery? Nitroglycerin or calcium channel blocker. So treatment will be with calcium channel blocker or nitrate. Now, during an acute episode of pain and ST segment elevation, you cannot tell who has prinzmetal, who has acute ST elevation MI. So you should treat everyone with the ST elevation MI, like as an acute MI. When you will go for coronary angiography for this patient, then you will find out that this patient doesn't have any block. So at that time, you don't need to do angioplasty. Clear? But this patient will be treated just similar like acute MI. So that finish our all MI angina things, and that's one of the important topic that we have just finished. Now move on to the aortic dissection. Aortic dissection, the chest pain is very sudden, severe, and it's midline chest pain, which feels like tearing or ripping sensation. And it goes or it radiates to the back and most of the time in between the scapula or shoulder blades. Sometimes it can radiate to the abdomen, flank, and leg also. The important diagnostic feature is inequality of the pulses. So you can get radioradial delay, you can get radiofemoral delay. That's also very important for aortic dissection. Although this delay is more common in coarctation of aorta, but anytime if you do radial pulse in both arm, you will see some delay in the both arm. That inequality in the both arm pulse, inequality of the blood pressure of the both arms, that's a very important finding for aortic dissection. Sometimes aortic dissection also can be complicated with hemiplegia, aortic incompetence as well. Consider a CT angiogram. Now, in your GEM, they say that best diagnosis is achieved by transesophageal echocardiography. So we will choose transesophageal echocardiography as our best diagnosis. Now remember one thing, if transesophageal echo is not there, then you should choose CT angiogram because that also is a very important or very good diagnostic modality. So either CT angiogram or transesophageal echo you will choose. But if both are there, then transesophageal echo because it's written in your JM. Aortic dissection, most of the patient will be hypertensive. So you need to treat the hypertension in those patients. Now the management is very important. Remember, aortic dissection comes in the exam many times, mainly with the management. See that this is your aorta, right? And you remember that your aorta has some branch which goes to your brain also or your neck, which we call brachiocephalic artery, carotid artery, subclavian artery, right? BCS. So brachiocephalic, carotid, and subclavian. Now, aortic dissection mainly divided into two parts or two subtype, type A and type B. Type A is if you divide the aorta based on subclavian artery, then distal to the subclavian artery, any dissection will be type B. Proximal to the subclavian artery, that is type A. The type A dissection has a highest mortality rate. And for those patients, your only treatment is to go for immediate surgery as soon as possible. But for type B aortic dissection, we don't usually go for surgery. Medical management or conservative management is usually the choice of management in here. What is the medical management you do? You control the blood pressure. How to control blood pressure in aortic dissection? The initial medication that you should start with is the beta blocker. Never choose IV nitroprusside as a first line because it can cause sudden drop of blood pressure and patient can get hypotensive, and it will be very hard to normalize the blood pressure if it drops severely in this patient. So for this reason, we will start with the beta blocker, mainly IV labetalol you can start with. After IV labetalol, because beta blocker, you can control the blood pressure without dropping too much. So start with the beta blocker, IV labetalol, and then still it's very high, then you give IV nitroprusside. Clear? So that's the management for your aortic dissection. Type A will go for surgery, type B, management of hypertension. Any questions so far? Okay, so whatever we're going to do, we'll finish here tonight. And then the next session, we will go for hypertension, heart failure. This will be our main topic. And normally for CVS, we need to take 3 classes. So this is the first class. And then next class, we will try to finish as much as possible. Mainly, we will start with the palpitation also, because palpitation is important. And after the third class, we will mainly finish the rest of the cardiac. Mainly we'll left with maybe some hypertension or dyslipidemia. And we'll also start with the cardiac question solvation in the third class. ECG is not included in here. ECG is for our course student. So those who join the course, usually we do the ECG class, usually after the cardiac classes. Okay. Yeah, the notes are similar as the slides. So this is the type A and type B. So it will be easier if we can show you here. Let me have a look. See this one. This is your brachiocephalic artery, carotid artery, subclavian artery. If any patient have dissection before subclavian artery, like this patient having dissection here. See, this is the tear here, and this is the false lumen where the blood is collecting. This is called a Stanford type A dissection. If it is distal to the subclavian artery, like here, then it's called a Stanford type B dissection. Yes, Dr. Arafat, we will give you the software access when you will join the class. We usually don't show it like in a live session like this. When you join the session, usually in our course, we show you how you can access the software and how you can get benefit from the software. Yes, the software will contain every notes which we take in the class. Not only that, all the last 2-year sample questions will be in your software with total solved answers. So anytime if you want to go through any questions, you can go through the software and you will find out we already have all those questions as a solved one. The software, we don't give past recordings. Is usually when we take the class, then the class recordings are uploaded in the software. But the previous students, like we have taken a lot of class in the past classes, but we don't usually give access for the past recordings. When we take your session, like today's session will be uploaded in the software like this. And yes, we have the books in the software, but some of the books are very, very large. So it will be difficult to upload it in the software because, and it can take a little bit time to open because it's very large. Some of the USMLE book like World USMLE is very large book. So in that case, we will give you the link of the book which you can download. All the books, we will give you the download link and you can easily go through that and you can download by yourself. Your next session is 6th November. We already updated the schedule in your first aid AMC MCQ group. Have a look into the picture. Always, if you want to know the schedule, what you should do, you should go to the photo section of our group. And when you go into the photo section, you will find out our schedule. Dr. Samrin, when we can join? You can join anytime. If you want to join our session or our course for the 5 months, you can ask us anytime to join. Normally, our team member usually works with this joining. So if you send us an email or if you send us message in our messenger, someone from the team member will answer your queries. You cannot download anything. It's already given in our software and it's a lifetime access in the software. You will get the software access all the time as long as you pass the exam. So you don't need to download it. You can go into the software and then you can read it whenever you want, but we don't allow you to download. I don't think you need download when you have access. All right, then. So we'll finish it here. Dr. Jubail, cardiology lecture 2. I'll have a look that if the cardiology lecture 1 is uploaded or not. Maybe it's not uploaded still because usually we upload after the session. Okay, thank you all. Have a good night and we'll see you soon again. Bye.